Hello, hello, hello. Good evening, students. I'm Dr. Punit Bhojani, your OBGY mentor, and we are here. Can I get a thumbs up if all of you can hear me, if all of you can see me from where we are streaming? There'll be a lag of around 10 seconds, so let me just know once whether we are live or not, and all of you can then also type something in chat box so that I know that the chat box is also functioning perfectly fine. So am I visible to all, audible to all of you? Is the sound and volume all okay? Yes, I think we are live now, and yes, hello. Okay. Yes. Okay. Yes. Thank you, Mukesh and Atul, for using the chat box function. Also, yes. So, welcome all of you to our. Yeah. Okay, great. Yeah, thank you, Devesh. Yeah, okay. So, welcome all of you to our session. This is the OBGY MCQ session for the upcoming FMGE examination. All of you know the exam was supposed to be in December, but now it's in Jan. So, please make maximum use of this one extra month which all of you have got. Okay, so let us begin our discussion, but before that I want all of you to make some important announcements so that all of you can participate. This is Ultra Combat 2.0, which is for different depending on your year, second year, third year, final year, intern, post intern. Lots of prizes are there. This is on 27th November at 12 p.m. Okay, so you have to enroll. You'll get lots of prizes like MacBook, iPad, mobile phones, and also gift vouchers and rewards and scholarships. Okay, and do not forget to use the code mentor, MENTOR, to enroll using the code mentor. Okay, so this is going to be very good. All of you, please, wherever you are, download the Unacademy app. 27th November 12 p.m. India time, this will be there. Okay, is it clear to all of you? Yes. Similarly, this is the various batches which are there in the Unacademy app. This is for the upcoming NEET PG examination, and even right now, okay, in the month of November end, I am doing a rapid revision course. Okay, so all of you, this is specifically rapid revision course for the FMGE examination. So all you students who are going to give the FMGE examination, November end is the OBGY sessions. By November end, I mean from 21st November till 28th November, till 27th November. Okay, so it's going to be 7 session, 14 hours of absolutely high yield MCQs. Everything you are going to discuss. Yeah, but Atul will explain to you that also when time permits, what is all that, the connotation and all that. Okay, yes. So it has to have a proper meaning. Okay, yes. So and MBPS Prof package is also there. The code remains the same. Mentor and compete is also live, where you can compete with your friends. So depending on your requirement, there are various subscriptions which you can use. And use the code mentor to get the discount if you already haven't enrolled. Okay, so with this, and all of you know, in plus subscription, live classes, recorded lectures, best teachers, question bank, test series, any device, anytime, device of your choice also. Iconic is also available, and all of you know the special class features, and raise the hand where the student can directly talk to me. Okay, so with this, all this as the information, and last time, do not forget to use the code mentor. Okay, now let us start this MCQ discussion program. I want all of you, these are all the extremely high yield MCQs in the previous year's MCQs we're going to discuss, very likely for the upcoming FMG examination. So I want all of you to participate in the chat box and answer. Right, wrong does not matter. Okay, so first question for the day, double marker test. It's also called as a dual marker test. So any idea what is this double marker test or dual marker test, and what will it have? Like when I say double marker, what do we do? What are the two markers? A, B, C, D, E. 5 options I've just given, and to like make them MCQ slightly tougher for all of you. Yes, all of you please participate. Right, wrong does not matter. All of us are here to make learn and make mistakes and learn from our mistakes. Okay, yes. So anybody, what is this test? First of all, what is this test, and this test is done for what? Okay, Devesh Singh is saying B. Okay, very good. So this is, anybody, what is the dual marker test, and can anybody tell me what is this test for? Okay, so point number 1, this is a screening test. That is the important point you need to keep in mind. This is a screening test for what condition? Okay, twin clearly saying A. Okay, screening test for what? This is a screening test for detection of trisomy 21 or Down syndrome. Okay, so it is not a confirmatory test. Okay, it's a screening test. If it is normal, very good. If it is abnormal, that means that it is showing high risk. I have to go for a confirmatory test. Now with this MCQ, I have an opportunity to teach you not only double, I'll teach you triple and quadruple also. So anybody and any idea when do I do this double marker test? At what weeks of gestation? When is this test done? All of you, if I ask you, is this done in first trimester, second trimester, third trimester? When is this dual marker test done? Any idea? Yes. Okay, so all of you please pay attention. The important point is, Atul, 16 weeks pay, yes, that is the triple marker test. So all of you please pay attention. There is a triple marker test and a quadruple marker test, which is done when the patient is roughly 16 to 18 weeks pregnant. Is this understood to all of you? So double marker test, triple marker, quadruple marker are done in the second trimester. I'm writing T2. And the dual marker test, which is the question over here, it is done in the first trimester, T1. And when is it done? 11 to 12. You can remember 11 to 13, but 11 to 12 yaad rakhenge to bhi chalega. So between 11 to 13 weeks of gestation is when you do this test. Okay, yes Atul, perfectly correct. 12 is a perfect answer. Okay, now what is that is, first of all, let me quickly take this time and explain to you all the tests, so that any of the question, there is a short question definitely going to come. So anybody, when I say triple marker test, what are the components? Sir, HCG, alpha fetoprotein and unconjugated estriol, ESTR. This is the E3. Okay, ESTRIOL. This is unconjugated estriol. Is understood to all of you? Yes, because there are three markers. What are the markers? HCG, alpha fetoprotein, unconjugated estriol. Now can anybody tell me, suppose the baby has Down syndrome. In case if the fetus is having Down syndrome, what will be the interpretation? What will go up? What will be higher? What will be lower? Anybody? HCG will be what? Where should I put the arrow? Arrow should I put up or arrow should I put down? Alpha fetoprotein, arrow up, arrow down. What should I do? Anybody? All of you, Devesh, Atul, Twinkle, all of you, those who are there. Twinkle. Okay. So in triple marker test, HCG is higher than normal, but alpha fetoprotein and unconjugated estriol are lesser than normal. Will you remember this? Yes, very good. So now anybody, what is the quadruple marker test? So sir, HCG first marker, alpha fetoprotein second, estriol third. Anybody, what is the fourth marker? Fourth marker is inhibin A. So clap if you feel happy. In the first 5 minutes of lecture itself, so many information you got. Triple marker ho gaya, quadruple. And again remember, inhibin is higher than normal in case if the baby is having a Down syndrome. So in trisomy 21, in patients of trisomy, if the baby has trisomy 21, what is the interpretation? So 2 arrows will be up and 2 arrows will be down. Is this understood to all of you? Inhibin higher than normal, HCG higher than normal, alpha fetoprotein estriol. So 2 up, 2 down. Clear to all of you? Now coming to the dual marker test. Dual marker test is very good. Somebody had said option B. Inhibin A is a part of your quadruple marker, estriol is a part of triple marker, HCG will always be in all the tests. Okay, so HCG and PAP A, HCG and PA. What is PAP A? Pregnancy associated plasma protein A. I repeat the full form, pregnancy associated plasma protein A. Sometimes they say placental associated plasma protein A, but that's it. Okay, and the interpretation over here is C. Easy to remember. In triple marker test, HCG kya hai? Arrow up. Quadruple marker test also, where is the HCG arrow? Arrow is going up. So here also what will be the HCG? Anybody, up or down? Anybody? Here also HCG arrow will be up or down. If the baby has trisomy 20, obviously higher only, okay, because if at 12 weeks it is higher, then only it will be higher at 16 weeks, 18 weeks. So this is triple marker test and quadruple marker test, both are done at 16 to 18 weeks. Okay, I'm revising everything. Okay, yes, so HCG arrow up, but PAP A arrow down. Okay, this is if the baby is having trisomy 21. So they can ask you also, all the questions are going to come in this exam, that if the baby is having Down syndrome, then in the double marker test all are elevated except, all are decreased except, like that. Okay, yes, perfectly correct. So this is understood to all of you. So many questions. Double marker test when done, 11 to 13 weeks. What is the interpretation? HCG PAP A, HCG higher than normal, PAP A lower than normal, and that is what it is. Okay, HCG and PAP A is a part of your dual marker test. Anybody? And then triple marker, quadruple marker, all that again we know. Okay, moving on. Anybody identify this device? What is this image based MCQ? Okay, and what are all the non-contraceptive benefits of this? Are all accept? Any idea? What is this device? Completely yes, it is like a T-shaped device, but is it copper T? No, I don't think it is copper. Why it is not copper? It is not copper. Why it is not copper? See, all of you, can you see, had it been copper T, तो क्या होगा? In copper T, it would have a copper wire wound round like this. Yes or no? The vertical stem would have a copper wire. Okay, is it clear? So this is not a copper T. Sometimes even in the vertical arm, horizontal arm, अगर ऐसा है, then you call it as a copper T. Yes, so this is not a copper T. Very good, twin Kai. This is a Myrina is a brand name, perfectly fine if you remember that also. This is a LNG intrauterine device. This is a hormonal barrel. This contains hormone. Anybody? And Myrina is a brand name, perfectly correct. And anybody, it is also called as LNG20. Can anybody tell me why do I call it as LNG20? LNG20, again a short contraceptive hot topic. Please do perfectly fine for the upcoming exam. Okay, and I want all of you to join the rapid revision course and meet me in the course during the classes. Okay, yes. How much is the LNG content? Two questions are asked in this topic, that what is the total LNG and what is released per day. So totally, any idea? Totally the LNG is 52 milligram. This has been asked to you. Okay, 52 milligrams, and 20 microgram is released per day. Is it clear to all of you? That is why, very good. Prishala correct, but beta not, no, beta Atul 65 is in progesterone acid. Okay, gone. And not 20 milligram, it is 20 microgram. Okay, MCG. Okay, is it clear? This symbol is also microgram. Okay, per day. Okay, is it clear? Now what are all the benefits? What happens is that it is releasing continuous progesterone. So progesterone is used in treatment of endometrial hyperplasia. Of course, yes, when I give continuous progesterone, all of you know, is going to counteract estrogen. It's opposite of estrogen. So it does not allow estrogen to act. So what happens is to the menses also, anybody, menses keep on becoming scanty, and even temporarily the menses stop. So I can use it in patients of menorrhagia and dysmenorrhea. Okay, we can use it in patients who are having, okay, heavy periods, menorrhagia, and even dysmenorrhea. Okay, so those who are having heavy periods, painful periods, because what happens to the menses? Sir, menses keep on becoming less. So patient says, doctor, initially I was having very heavy periods. I was passing clots. I was bleeding for 7, 10 days. Then you put Myrina, because of continuous progesterone, the lining does not grow so much. So menses become less, and then even menses can even stop, but not to other. This is safe. Okay, so it is like a progesterone induced amenorrhea. Because of continuous progesterone, the patient's menses can stop. Progesterone induced amenorrhea. More details we explain to you in the classes. So menorrhagia में कर सकते हैं, dysmenorrhea में we can give it, endometrial hyperplasia. Also because of progesterone, the cervical mucus would become thick, and therefore PID episodes would become lesser, pelvic inflammatory disease. So even ectopic pregnancy becomes lesser. When you use birth control, you don't become pregnant. It's a method of contraception also. And I told you dysmenorrhea and menorrhagia also. So what is the answer? Answer is D. It will decrease the risk of CA endometrium. Because of progesterone, CA endometrium risk becomes lesser, but it is not connected to cervical and breast cancer. It cannot decrease. Okay, so that's the answer. Okay, in fact, if there's a breast cancer, we should not use it. Okay, so decrease the risk of breast and cervical cancer is the answer. Which you are not supposed, Myrina cannot do that, but it can decrease CA endometrium. Okay, decrease the risk of CA endometrium definitely is decreased. So can all of you tell me, apart from contraception, I repeat 5-6 benefits: menorrhagia, dysmenorrhea, ectopic pregnancy, endometrial hyperplasia, prevention and treatment, and decreased risk of endometrial cancer. Okay, all these are the benefits of your Myrina. Okay, or LNG IUD. So this is a very, very important topic. Everybody should know all regarding this. Okay, I repeat, total it contains 52 milligram, and by the way, it is for 5 years. Once you insert it, you can use it for up to 5 years. Okay, it's for 5 years, and 20 microgram per day. Okay, let's go on to the next question. Yes, very simple. If a baby, this again, it's a simple MCQ, but I've kept it because in FMG likely to come. The baby is found to have transposition of great vessels, TGA or TGV. What should the mother be investigated for? Anybody? Chalo, all of you. That means which of the following? Yes, all of you. चलो A, B, C, D क्या है? पर टाइप करिए चैट बॉक्स में. Yes, Afreen, perfectly correct. If the mother is having uncontrolled diabetes, specifically in the first trimester, okay, not Lakshmi positive, I have no D. Okay, this is a very common mistake. Wherever the fourth option is all of the above, the students will mark that only. Mukesh nahi. Okay, D nahi. Okay, preeclampsia is a condition which happens after 20 weeks. Okay, after 20 weeks, and mother's blood pressure will be high. उसमें क्या हो सकता है with preeclampsia? There could be IUG or IUFD. This is a congenital anomaly in the baby. Okay, congenital anomaly is there in the baby. So that can happen if during organogenesis. Okay, if in the first trimester. Similarly, SLE say baby can have congenital heart blocks, but not this. So whenever the mother has diabetes, and can anybody tell me what are the other anomalies? When the mother has diabetes, okay, and we call it overt diabetes. Overt matlab ke before pregnancy only. Okay, before pregnancy, if the sugar is uncontrolled, and during first trimester, if the sugars are not controlled, if the sugars are uncontrolled, then what can happen? Baby can also have a abortion. The pregnancy can get aborted, as well as there could be anomalies. And as the pregnancy will advance, anybody, suppose the sugars become abnormal at 5th month, 6th month, what are the other things? Yes, macrosomy can happen. Yes, very good, Lakshmi. We are going to discuss that. So when we look at this anomalies, most common anomaly is the ventricular septal defect, VSD, and also neural tube defects. Okay, so VSD is the most common. Yes, very good. Okay, VSD, neural tube defects, and we also get transposition of great vessels. Very good. Okay, and what Lakshmi Pawar was telling, Lakshmi Panwar, that is the most common and the most specific anomaly is the sacral agenesis, also called as caudal. Anybody what is called as caudal regression syndrome? Okay, sacral agenesis or caudal regression syndrome is the most specific anomaly in the baby of the diabetic mother. Extremely important MCQ and perfectly correct. As the pregnancy will advance, the baby can have polyhydramnios, macrosomy, big baby. So big baby. Okay, so after delivery, during delivery, shoulder dystocia. So all these are the yes, and positive is perfectly. After that's again a pediatric MCQ trick. After the baby is born, hypoglycemia in the newborn. Okay, so there could be polyhydramnios, macrosomy, shoulder dystocia. Okay, prolonged labor, all that, more chance of cesarean section. Okay, so I repeat, keep all these questions in mind. Most common anomaly, ventricular septal defects number 1, neural tube defects number 2, transposition of great vessel is also very important, very classical, and overall the most specific anomaly is sacral agenesis or caudal regression syndrome. Is this clear to all of you? Yes. So when the baby is having this diabetes, specifically if it's a pre-existing, not all of the above. Okay, yes, let us go on to the next question. Yes, anybody, this is a image, I'll tell you, it's a ultrasonography of the uterus. Okay, this is a transvaginal sonography. Can anybody tell me, this is the uterus, and what are we seeing inside the uterus? Okay, what are we seeing? See, this is what is this? So can anybody tell me the diagnosis? What is this? Very classical picture. What is this? Yeah, all of you, yes, very good, but what's your diagnosis? Anybody? This is typical what? So this is called as, yes, snowstorm appearance. Very good, all of you, excellent. Snowstorm appearance seen in vesicular mole. Okay, so vesicular mole or H mole, hydatiform mole, as we call it as H mole or V mole. Okay, you call it as H mole or also hydatiform mole or V mole. Okay, so basically this is a defective pregnancy. It's a hydropic degeneration of the chorionic villi, where all the chorionic villi you can see are replaced by multiple fluid filled grapes like vesicle, and this is a complete mole because there are no fetal parts. Anybody, suppose if I also see some baby parts along with it, तो उसको क्या बोलेंगे? What will I call it? If the baby is also there with a snowstorm, if some fetal parts are seen, then you call it as partial mole. Okay, is it clear? In partial mole, some fetal parts are seen. In complete vesicular mole, the treatment will not differ. The treatment is the same. The treatment is the same, if only. So you can see clearly the same picture is there. Yes. Okay, so this is the typical very famous multiple snowstorm appearance and multiple fluid filled grapes like vesicle in the uterus. Perfectly correct. Please don't do cesarean, stupidity. Okay, you're not supposed to do cesarean section. Okay, so that is out. Forceps kuch nahi. And why never? Please understand, this will always be in the option, never induce labor. Why never induce labor in vesicular mole? Because it is not a well-formed pregnancy. If I make the uterus contract, please understand, if I make the uterus contract, what will happen is that few grapes like particle will come outside and lots will remain inside. A lot of chance of retained products. So over here, whether it's a complete mole or a partial mole, complete or partial, the treatment is rightly told by all of you, suction evacuation, and that is the answer, option number A. And this is the only condition, students, where even if the uterine size is bigger, normal pregnancy we can do suction up to 12 weeks, but here suppose if they give you, let's say patient has a vesicular mole and the uterine size is bigger, 16, 18, 20 weeks, 24 weeks, whatever may be the size of the uterus, the treatment is still going to be suction evacuation. Is it clear? And after doing the suction evacuation, which hormone do I monitor? This was also asked in last year's FMGE exam. After I suck out the vesicular mole, which hormone estimation I should do? It should keep on becoming less. What should keep on becoming less? Very good. HCG hormone should keep on declining. Very good. All of it is again a very important, perfectly correct, all of it. Okay, so snowstorm appearance, complete mole, partial mole. Let's move ahead. Yes, again this was a very famous, okay, completely everything we should know. There was a question on MTP, medical termination of pregnancy with the help of tablets. What are the Beta Devesh, what is done is first you do weekly. Okay, we do weekly it should keep on declining. So initially after the suction evacuation, of course you do a pre-evacuation, then weekly HCG is done till it becomes negative, and once it has become negative, even monthly can be done till 6 months. Okay, so weekly testing till it becomes negative. Okay, negative matlab less than 5. So the levels of 50,000 it declines. So every weekly you keep on doing, it should keep on decreasing. Okay, yes. Now what is this? Positive I was saying C, Afrin is saying C, Alok is saying A. Okay, yes. So please understand this. This is for MTP, medical termination of pregnancy with the help of tablets. So this is called as medicated abortion, or with the help of medicines. Okay, so please pay attention. Here you should know everything. That just remember the combi kit. This is how the kit would be coming. Okay, there is one tablet which is what, and there are 4 tablets which is what. What is this first tablet? Sir, this is mifepristone, also called as RU486, and this is a 200 milligram tablet, and always we give mifi first. Okay, so that is not, see यहाँ पे 200 microgram दिया है. Okay, that's why A is not the answer. Okay, is it clear? So please keep in mind, and meso we never give first. Why? We never give meso first and then after 48 hours. No, it's always mifi first. Again here see, this option is out because यहाँ पे meso first दिया है. Very good. So this is the answer. Okay, please keep in mind. Now what is it is, how do I give, and what does mifi do? Anybody? Mifepristone is a anti-progesterogenic hormone, a tablet. So once I give, it's an anti-progesterogenic property, so it will stop the progesterone, so pregnancy cannot grow, because in early pregnancy progesterone supports the pregnancy. So this is given on day 1, and then on these 4 tablets. What are these 4 tablets? So these 4 tablets are misoprostol tablets. What is misoprostol? It is PGE1 analog, prostaglandin E1. Everything is asked to you, and this is given after 48 hours. So that's on day 3. Okay, so you can see there has to be a gap of 48 hours. That is the classical thing. Some, even if you keep 36 hours, it's okay, but at least keep a more you give. So what does mifi do is, okay, mifepristone, anti-progesterone, blocks the progesterone. It also makes the uterus and the cervix more favorable to action of meso. And then misoprostol, PGE1, it will make the uterus contract, cervix will open up, and rightly told, each tablet is 200. So remember, both are 200, but this is 200 milligram and this is 200 microgram. Is this understood to all of you? So, and there are 4 tablets, 1, 2, 3, 4. So then it becomes 800 microgram, which could be used per vaginally also, buccal also, sublingual also, and the pregnancy will get aborted. And anybody, what is one information you tell the patient? Anything else to be after these tablets you gave to the patient for MTP? Does the patient need to come back to you for follow-up or not? And what the success, if they ask you what is the success of this combination, mifi meso combination जो दिया है, so books mention technically around more than 96% success rate is there, 96 to 98% actually. In my practice to more than 99%. Okay, so that means you need to make sure that everything is clear. So generally we have to do ultrasonography. Generally ultrasonography should be done after 14 days to make sure that the uterus is completely clear, there's nothing inside. So that is called as retained products of conception. Okay, yes Devesh, follow-up is done, ultrasonography to rule out any retained products, because the pregnancy, some bits remain inside, there would be a bleeding all that. So generally recommendation is after 14 days we can do the ultrasonography. It is advisable to make sure everything is clear. Okay. Yes, so everything we should know about this mifi meso, don't make a mistake student. So therefore this is the answer, mifepristone 200 milligram and misoprostol after 48 hours. Okay, is it clear to all of you? Yes. Moving on, and you will come back to this image. Yes, now this is again a very important question. When I do a DNC, what is DNC? Dilatation and curettage. What is the sequence of events? Okay, 1 2 3 4 4 steps are told to you. Can anybody tell me what is the sequence of events? Yes, so point number one, very good. MBBS surgeon is saying A, positive is saying B. Okay, yes, A. Okay, so point number one is K, you need to first do a PV examination. Yes or no? A PV examination should be done for what? To find out what is the size of the uterus and what is this. So first I determine the size of the uterus by ultra, whether the uterus is anteverted or retroverted, and what is the size, bulky 6 weeks. So first I determine the size and this. So 4 is definitely the first step. Okay, so this is out. 4 4 4 yahan pe hai. Then what I do after 4, we go and do the uterine sound. Anybody, what is the uterine sound? Uterine sound is an instrument. Okay, it is like this. Okay, it is like this. Okay, this is a uterine sound which you put inside the uterus. So what do I come to know with it? We come to know the uterocervical length. We come to know the uterocervical length. It also acts like a first dilator. Okay, so uterine sound tells us about the uterocervical length. So that sounding of the uterus should be done. So 4 will be done. Then I go to do number 1. Okay, that is the uterine sound. Then obviously, very good Asha. Okay, and then I have to do dilatation. What is the name of that instrument? Hagas dilator. Okay, Hagas dilator is used to dilate the cervix from number 4.5, 5, 6. Come to this. So then it's going to be 2, and lastly of course we will do the curating. So 4 1 2 3 perfectly correct. Option number A जो था वो curating has to be last, right? इससे भी देख लोगे कि curating will be last. DNC name is dilatation, curettage. So 2 and then 3. Here 3 has to be end. See all the other numbers. That's also a clue in the exam. Okay, that is out. Why it is out? Because यहाँ पे number 1 last में है, number 4 last में है, number 1, so that is out. Is it clear to all of you? So I repeat, PV examination first, then put in a uterine sound, then dilate and then curate out. Okay, so don't make a mistake in this MCQ. Which is not a part of biophysical profile. Biophysical profile, it is also called as Manning's score. It is a test for fetal well-being. It's a test. What is the test? What is the meaning of fetal well-being? That whether the baby, it is done in the 3rd trimester. Okay, this BPP is done in the 3rd trimester, 34, 35, 36 weeks. Okay, it's a test for fetal well-being, that I want to know whether the baby is healthy inside the mother or do I need to get the baby out. So this test tells me when and how to deliver. So all the high risk pregnancies like pre-eclampsia, IUGR. So which patients to do BPP? What are the indications? Indications kya? I'm just giving you. There's pre-eclampsia, there's IUGR, there is oligohydramnios, there is postdatism, all this, diabetes in pregnancy. Okay, because suddenly the baby can die. So all these patients, we should do this. Yes, NST, very good. They were saying NST is non-stress test. Okay, so NST is a part of it. NST I do. Okay, NST is non-stress test. Okay, Devesh. And along with it, other 4 components are done. Okay, other 3 components. So totally there are 5. Okay. Totally there are 5 components. NST is part of it. So total 5 components. Each component is given 2 marks. The other 4 components are done using ultrasonography. and in that what is done is we look at the fetal tone. But remember, this fetal kick count is the answer. Fetal kick count, why it is the answer? Because this mother counts the fetal kick count. In fetal kick count, we tell the mother that please count whether your baby is moving or not. That is not a part of BPP. In BPP, yes, fetal, I'm writing F. F stands for fetus. Okay, is it clear? So yes, fetal movements are checked. But who will check this fetal movements? Anybody? Who will check this fetal movements? Anybody? Patient, husband, doctor, neighbor, who will? So radiologist? Yes. So on ultrasonography. So the sonography doctor, you have to do ultrasonography for 30 minutes. So all these details you are not supposed to remember, but ultrasonography is done for 30 minutes, and then we tell whether baby is having movements or not. Fetal breathing movements are also taken. Breathing movements, and there should be movement of diaphragm, and how much is the amniotic pocket. Okay, amniotic fluid ka pocket, there should at least be a single pocket which is 2 by 2 centimeter. Is this understood to all of you? So these 5 components, NST, non-stress test you do, remaining 2, 3, 4, 5 is done with ultrasonography. Keep that in mind. Okay, so basically it's a combination of NST. What is BPP? Sir, BPP ke liye I do NST plus ultrasonography. And in ultrasonography, what we measure? We measure the 4 components: fetal movements, matlab gross body movements, fetal breathing movements, fetal tone, and amniotic fluid around the baby. Okay, so all this is important, and if the score is decreasing, basically it will tell you there is fetal distress. Anybody, what will happen if there is fetal distress and I don't deliver the baby? What will happen? Anybody? So what is the purpose of doing this testing? If somebody asks you, what is the purpose? What is the ultimate aim of doing all this testing? So the ultimate aim of this testing is to prevent IUFD. Baby will die inside the mother. Yes or no? If there's fetal distress and if I don't act, yes, meconium aspiration, baby will die. Okay, to prevent IUFD. That is the main purpose. Is it clear to all of you? So that's the main thing why we can detect fetal distress, and then the baby is giving you indication that get me out. Okay, yes. Now again, this is a very yes, very good, Akash. Okay, so identify what is this image. Can anybody tell me what is this image showing you? So all these are extremely high yield MCQs which could be asked to you in the upcoming exam. So what you can see is that, sir, here what is happening? Okay, sir, here there is a main placenta and a small accessory lobe, and both of them are connected by vessels. So this is called as, yes, this is our succenturate lobe of the placenta. Okay, so main placenta hai and uske बाजू में और एक accessory lobe है. So this is the succenturate placenta, succenturate lobe. Anybody? Placenta previa I can't make out after the delivery. Placenta previa is a diagnosis which I make on ultrasonography. Okay, why? How can I come to know by ultrasonography? That when, if this is the uterus, if the placenta is down over here, the placenta is down over here, then I call it, this is called as placenta previa. It's a placenta is in front of the presenting part. That is placenta previa. Okay, yes, painless bleeding. And normally you have seen, all of you, have you seen a placenta? Yes. Where is the umbilical cord attached? Sir, umbilical cord is attached at the center of the placenta. Okay, at the center of the placenta. Okay, but if this is the placenta and umbilical cord is attached at the margin or the periphery, then what do I call this? What do I call this placenta? If this is the picture given to you, and from here the vessels are coming like this, yes. So this is called as Battledore, B-A-T-T-L-E, Battledore placenta. Okay, umbilical cord inserted onto the placental margin or periphery. Very good, Prishala. Okay, is it clear to all of you? So Battledore placenta. Okay, so all these are, so this you can see in this picture, what we can see. So there is this one lobe and there is this another lobe which is at the periphery. So this is a succensurate lobe which can get retained during the delivery and can cause atonic PPH. Okay, okay, yes. Yes, very simple question, again very high because it's a very high topic, preeclampsia. Okay, so patient is having BP of 150/100. Okay, there is associated proteinuria. So anybody, what's the diagnosis of this patient? Clinical case, 22-year-old patient. All of the following are expected complications except. Okay, so read the question correctly. So what's your diagnosis, anybody? The diagnosis is what? Anybody, what's the diagnosis? High blood pressure, BP 150/110 and proteinuria. Yes, very good, Aditya Singh. It is preeclampsia. So basically the simple question है, one liner है कि all are complications of preeclampsia except. So what can happen with preeclampsia? Of course there can be eclampsia, of course that's the most dangerous complication. Will there be abruption? Yes, abruption is a very important complication. Okay, abruption is a premature placental separation. And anybody, what is this HELP syndrome? What is HELP syndrome? Very important. What is HELP syndrome? So HELP syndrome is, H stands for what? Hemolysis. The blood will get hemolyzed. Hemolysis. EL stands for elevated liver enzymes. That means what will happen? Your SGOT, SGPT all, and LP is low platelets. Okay, please don't make a mistake. It's a very famous MCQ. Elevated liver enzymes. And low platelet. Low platelet matlab less than 1 lakh. Okay, less than 1 lakh. I repeat, that's again a complication of preeclampsia. Hemolysis, elevated liver enzymes, low platelet, that's a dangerous complication of this. And there could be abruption and there could be PPH also. Yes, perfectly correct. Macrosomia nahi hoga. Macrosomia you get with diabetes. Are all of you understanding this? This, in fact, here we get IUGR, because when the blood pressure is very high, the baby will not get adequate blood supply. So there's a preeclampsia in the mother will lead to IUGR in the baby, not macrosome. Okay, so first number 1 is the answer. 2, 3, 4 all can happen. Okay, is it understood to all of you? And very simple, again a very popular MCQ. I've got time for the last question. Yes, anybody, this is what imaging? This is a X-ray, but in the X-ray we have put some contrast. So this is a hysterosalpingography, HSG. And what do you see in this HSG? Okay, so all the different important questions are asked. So normally if you focus, look at the uterus. Okay, normally the uterus has a triangle cavity. In HSG, the uterus will have a triangle cavity with the tubes having a very bouncy wavy tubes. And then what do you get over here? This is called the spill of the dye. Okay, the dye, it's a test for tubal patency. Okay, so normal uterus is, you can see a triangle cavity. Here what we are seeing is only one side of the uterus is being seen. Yes, so this is not a normal HSG. No. In Asherman syndrome, what is Asherman syndrome? Intrauterine adhesions. So in that we get multiple filling defects. Perfectly correct, all of you. This is a unique, or you can see all of you. Okay, I'll draw the outline. Okay, so all of you can see this. Let's say here what has happened is that only one side, like a banana shaped uterus, okay, and then this tube has gone all the way like this, there's nothing. Okay, so this is a banana shaped uterus or a unicornuate uterus. Okay, so please keep this in mind, because this is a very popular image which could be asked to you in the exams. Okay, is it understood to all of you? Because only one side of the uterus is seen, okay, which is a unicornuate appearance. Okay, so I thank all of you. Okay, it's a beta, it's a iodinated, okay, it's a Condray, okay, urographene or Condray iodinated dye, okay, oil based dye, lipid based dye, multiple dyes are used, okay, urographene, okay. So it is HSG, hysterosalpingograph. It's mainly a test for tubal patency. Okay, so thank you very much for coming in today. That's our time. I wish all of you best of luck for all the upcoming examinations, and as I told you, please download the Unacademy app. Do not forget to give the code is mentor, MENTOR. Do not forget to go in for the combat exam which is there on the 27th of November. And as I said that we are starting with a batch, the OBGY sessions are starting from 21st of November. Okay, 21st of November, that is Monday 21st November, everything will be discussed, questions, previous year questions, images and everything. Okay, so bye bye, best of luck. Thank you very much for coming in for the session. And this, yeah, beta ऐसा नहीं होता बेटा, G3 P3 नहीं होता है, that is wrong thing. L4 A2 all that is, so we'll have to explain to. G is gravida, P is number of times the patient has become pregnant, A is living issue and abortion. Okay, so when the patient is, if she is pregnant for the third time, she can't have previous 3 deliveries. Okay, so G3, okay, and she can't have 2 living 4. Okay, so there she could have 1 twins. Okay, she is abortion 2, so it's not matching beta. Okay, because otherwise, or it can happen is that 2 times she has undergone abortion and directly quadruplets. Okay, but still it's not matching. Okay, so Atul saying the number is galat. G is, I can only explain to right now that G is gravida, P is parity, number of time pregnancy, L is living babies. So in 3 times, third time pregnant she is G3. So in previous 2 pregnancies she has got 4 babies. So she could be previous 2 twins, previous 2 time twins. Yes, it could be previous 2 time twins and then abortion also 2 times. It should be G4 hona chahiye. Okay, is it clear? So both time previous 2 twins. Okay, so Atul, thoda numbers matching nahi ho raha hai. Come to the live class in detail, will explain to you, but this is what it is. Okay, if it's a previous twins. Okay, but these numbers are not matching. It can be G3 P3 L4 A2 nahi hota hai. Okay, because abortion 2 itself is telling you she is pregnant and now again pregnant. So so it should be at least G4 minimum hona chahiye patient. Okay, bye, best of luck. Thank you very much for coming in today and see you in the upcoming lectures. Okay, I hope I try to answer your question. Yeah, and best of luck for all the upcoming exams.